Distinguished colleagues, ladies and gentlemen, it is my pleasure to present on the health sector response to COVID-19 on behalf of Professor Mosa Moshabela. So we would at the outset like to acknowledge the invaluable support from Gtac, the NRF and the TPME, and we'd like to extend special appreciation to Dr. Marie Kirsten and Sinen Tsekiso for their invaluable support throughout this journey. These are the authors that contributed towards this chapter, and they are Mosa Moshabela, Carolina Paul Albertine, Sibusiso Sifunda, Karen Begg, Bryce Gebertstein, Priscilla Reddy, and of course myself. Our chapters consist of 8 sections covering the introduction, which includes the background, governance structure, organizational framework, theoretical lens and interventions, followed by epidemiology, biomedical and clinical aspects, healthcare system response, public health interventions, social behavioral interventions, our vaccination campaign, and then conclusions and recommendations. Our chapter sections resonate with the health sector intervention package from the National Department of Health. The chapter covers the critical elements of the intervention package, and the only addition is the vaccination campaign that comes in towards the tail end of the report. So this slide describes the political and technical leadership. The Minister of Health visibly led the response from the very first case and continues to do so today. The Minister works with and reports to the National COVID Command Council of the Cabinet and the Presidency, and also works with the National Health Council in implementing the mitigation strategy. The Minister of Health appointed the Ministerial Advisory Council, Advisory Committee of 51 persons, and later a separate advisory committee on vaccines. The item highlighted in yellow is the incident management team, and this team leads the technical response and supports all of the disease control committees in the districts and the provinces. IMT was really the hub with spokes across districts and the provinces. So this slide provides an overview of the 8-stage response, broadly covering preparedness, containment, mitigation, and recovery. We went through each of these stages more than once as we experienced different waves and outbreaks. So stage 1 was focused on preparation, community education, capacity building, and surveillance, followed by stage 2, which was primary prevention, social distancing, reduced gathering, and border closure. Stage 3 was the lockdown with curtailment of human interaction. Stage 4 was surveillance and active case finding. Stage 5 was hotspot identification with timeliest interventions and monitoring of new cases. Stage 6 focused on the provision of quality medical care and upscaling the surge capacity in preparation for the peak of transmission during the mitigation phase. Stage 7 spoke to bereavement and managing the psychological and social impact. And finally, stage 8 was the ongoing vigilance, monitoring antibody levels, vaccine actions, and ongoing surveillance for new cases and imminent waves. So the initial response sought to flatten the curve, that is, delay and reduce the peak of the epidemic curve such that we could prepare the health system. Several measures were put into place to prepare the healthcare system for the large number of cases anticipated through modeling at the height of the pandemic. This was to really relieve the pressure on the health system as the pandemic evolved, or the epidemic evolved in South Africa. These are a list of surveillance indicators, and we get feedback on this every single day, and they cover new COVID-19 cases per day, the testing rate per unit population, the percentage positivity rate, the active cases, the recovered cases, the current hospital admissions, COVID-19 mortality, as well as all-cause mortality. And this has really been useful, especially within the health sector, to monitor the progression of the disease by province and nationally. This is quite a busy slide, but this shows the progression of the disease from March 2020 to March 2021, 1 year, showing the 2 waves, the alert levels, and the interventions. We're all aware that our second wave was much more intensive, and we started up with strict lockdown measures At level 5, which started up on the 27th of March last year, it was eased a month later to level 4, then level 3 on 1st June, level 2 on the 18th of August, and level 1 on the 21st of September. We then reinstated level 3 on the 29th of December and eased it again on the 1st of March of this year. Our interventions ranged from healthcare, hospital and clinics, to the social environments, that is household, transport systems, and workplaces. Sorry, my apologies. Okay, that's taken care of. In the early weeks of the pandemic, new cases were mainly imported, and the surveillance of ports and travelers was the primary focus. After the borders were closed, local transmission became the priority. When the lockdown was introduced, surveillance shifted towards monitoring the contacts of cases and the emergence of community transmission with known contacts. And as community transmission took hold, containment and mitigation strategies became the primary focus, necessitating the coordination of outbreak response teams. And these range from curfews to closing down of restaurants, limited capacity for social interactions, the closure of mosques, churches, and synagogues, and the curtailment of numbers of people in social and religious gatherings. So this is a slide on the COVID cases and provincial trends. We will go clockwise, starting on the top left. The first graph is on cases, hospitalizations, and death. And you can see that they follow a similar trend of peaks and troughs. The second, the second graph speaks to cumulative cases over time in each province. There are 4 main provinces that have the largest number of cases, that is Gauteng, the Western Cape, KwaZulu-Natal, and the Eastern Cape. Initially, the highest burden was in the Western Cape, but the Western Cape was then overtaken by other provinces. The third graph shows that Gauteng had similar first and second waves, while the second waves were much higher in the Western Cape and KwaZulu-Natal. If you look at the Eastern Cape, the first and second waves were almost similar in height, but the second wave, you'll note, has a broader base. It was extended over a greater period of time. And then the final graph highlights the fact that the low burden provinces actually require equal attention. So we focus a lot on the high burden provinces, but you'll notice that Limpopo, who was very low in terms of cases in the first wave, actually had a very high second wave. This slide shows the cumulative cases after the second surge. It shows the cases relative to the population, and you will see that there's a mismatch between the number of cases per province and the burden of disease. So for example, the Eastern Cape had the largest burden of disease, followed by the Free State. There was a difference in case numbers and proportion population affected, so case numbers were not necessarily reflective of the disease burden. And burden was also reflected in the capacity of provinces to cope with the hospitalization and death, for example, in the Eastern Cape. In terms of mortality, the South African MRC monitored excess mortality and indicated that deaths designated as non-COVID-19 could have been as a result of COVID-19 or due to interventions to mitigate COVID-19. Although excess death cannot be conclusively linked with COVID-19, research is underway to provide a detailed account. So this shows the currently available vaccine options. As you can see from the picture on your right, there are different technologies used to create these vaccines. Some require single doses. Well, actually, only one requires a single dose. Most require 2 doses, and there are different cold chain requirements. You are no doubt aware that we are rolling out the Johnson & Johnson and Pfizer vaccines at the present time. And here on this part of the chapter, we focus not on rollout, but rather vaccine options based on efficacy in response to the variants. So our second wave was driven by the variant B1351, initially called the South African variant, and I saw a question in the chat. We are now the beta variant. So the WHO has renamed the variants. The UK variant is now the alpha variant. We are the beta variant. The Brazilian variant is, I think, Gamma, and the Indian variant is Delta. Or I might have got the last two confused, but that's the new naming to remove the focus on countries. So our second wave was driven by the Beta variant, and our variant actually affected the vaccine choice. You will recall that we had initially purchased large amounts of the AstraZeneca vaccine, which did not have the required efficacy against the Beta variant. And then we went with the Johnson & Johnson vaccine, which was initially rolled out to healthcare workers and continues to do so today. And we've now started vaccinating the over 60-year population with the Pfizer vaccine. And we expect to continue with both the Johnson & Johnson and the Pfizer vaccines going forward. So the key findings from all of the work that we conducted was that the healthcare system was strengthened by leveraging both the public and private healthcare sectors, hospitals, and GP networks. So both the private sector and the public sector came together to address the COVID-19 pandemic. The restriction of movement, which limited demand on the healthcare system, restriction of alcohol linked to reduced demand for emergency care following trauma and accidents, prolonged prescriptions for chronic medication intended to reduce the demand for chronic care services, particularly on the primary healthcare services. There was freezing of elective procedures designed to reduce the demand for routine surgical care. And the one problem that was widely reported to struggle with admissions was the Eastern Cape, and this necessitated direct intervention from the minister. So all of these things assisted the healthcare system to be better prepared, especially the alcohol ban, as well as the cancellation of elective surgeries. The complexity of interventions and long-term implications, the effective control of outbreaks depended not only on isolation measures being implemented effectively, but also on maintaining the chain of all measures intended to prevent infection at all vulnerable points in the cycle of disease transmission. However, restricted movements, temporarily suspended healthcare services, fear of acquiring COVID-19 in healthcare facilities, and lack of funds to access healthcare due to income losses in the communities was a unintended collateral damage. Noted unintended consequences resulting from the redirection of services and resources, such that some care was compromised and may have contributed to excess mortality, and the full scale of long-term implications of these complex interventions is yet to be determined, but some indication of double-edged ramifications have been there of gains and losses and trade-offs. So our key recommendations, 9 in number: strengthen data systems and science for decision-making, strengthen outbreak prevention and containment measures, integrate behavioral interventions into the health sector, protect vulnerable individuals, groups, and communities, limit unintended consequences and excess deaths, ensure supportive legislation to protect public health and well-being, monitor measurable outcomes of vaccination campaigns, maintain case-based and genomic surveillance for variant detection, and conduct implementation studies for vaccination rollout to monitor safety and effectiveness. And with that, I end my presentation and look forward to the comments.